Welcome to Living Transplant,
the podcast that takes you behind the scenes of the transplant program at Toronto General Hospital
and brings you open and honest conversations about the transplant experience.
My name is Courtney, and I'm the communications specialist for the Center for Living Organ Donation.
And my name is Brittany. I'm a bedside nurse in the Ajamira Transplant Center.
Full disclosure, we are not physicians.
No, and we are not here to give you medical advice.
Think of us like your guides through the world of transplant as we know it.
Whether transplant is your past, present, or future, your passion, or your curiosity,
Living Transplant will show you the world of transplant like you've never seen it before.
We just did an interview with Dr. Clarke, pain services at Toronto General. He was amazing. I swear we could be here till 10 p.m. tonight just talking about different ways to manage pain. But we definitely scraped the surface with a lot of these big topics on pain management.
But I kind of liked getting a little taste of all these different issues. Like so many areas in medicine, it has so much detail and so much depth and so much going on, especially when Dr. Clarke was talking about it, seems so current. I don't know if that's
I was just about to say, I'm like, although we're talking about obviously transplant and pain management and the pain services that we offer our transplant patients, it's so relevant to everything that's going on in the world right now. Obviously throughout a pandemic and all these other social issues, it's so interesting.
Absolutely. And I think especially talking about opioids, there's so much fear around opioids and a lot of questions that we got for this episode. Basically, the subtext of a lot of the questions were, I'm afraid of getting addicted. What if I don't want to take opioids? And again, I'm sure we could do a whole episode on misconceptions around opioids, but he really helped to kind of clarify that, it is actually quite rare, but what's a better story for the news? And not saying that we aren't in an opioid crisis, but it's not as common as it's made out to be.
Right. Yeah. Another spin-off episode would be the CBD and THC effects on transplant.
Absolutely.
Honestly,
I thought that was fascinating.
It is so fascinating. It is so fascinating, but it's he's so right when he says that Canada totally took over the control of CBD and THC and not having any type of scientific drive to it, because they're just oh, it's recreational. But now people are oh, it'll help me with this, and oh, it'll help me with this. And you have it at your disposal, almost dosing yourself based off of what this guy in the dispensary said. And it's no, you have to remember, you're trying to treat a medical problem. This man in this store does not have any type of doctorate beside his name to be able to diagnose and treat in the 5 minutes that you're in this dispensary. So how do you go about addressing those issues with naturally in our climate, given that it's legal in Canada? I would imagine that a lot of people would try to resort to something more natural, and that being THC and CBD, and thinking that it's totally okay because it's natural, when really and truly there's so many effects that it can have on you.
I think people, the natural versus the chemical, I think everyone forgets that chemicals are in everything.
Right.
They're chemicals are in your brain naturally. So it doesn't really matter if it's synthetic or not. It still has an impact on your brain. So talk to your doctor before you use any THC or CBD products for sure. And I guess we didn't get to ask him, but what is your guess of what his zodiac sign is?
Oh boy. Scorpio.
Oh, interesting.
That'd be one of my guesses, but let me sit on that for a minute. What do you think?
That's interesting.
He's probably,
I don't know anymore. All my confidence
Capricorn.
has been totally
Capricorn.
Yeah.
Okay. Yeah. I need to know. Can we email him? But I need to know.
Yeah, that can be in our follow-up. P.S.
Thank you so much.
What's your sign? Yeah, super professional question.
Yeah.
Anyway, sit back and enjoy this episode about pain. And please write in if you have any follow-up questions for Dr. Clarke.
Because maybe we can do another episode.
Yeah, give us a reason to do part 2.
Please.
Welcome back to Living Transplant. Our guest today is Dr. Hance Clarke, Director of Pain Services and the Medical Director of the Pain Research Unit at Toronto General Hospital. Thank you for joining us today, Dr. Clarke.
It's a pleasure to be here, Courtney and Brittany.
So what is your connection to transplant?
So, I happen to work at Toronto General. I'm a staff anesthesiologist. I direct pain services. And we all know that TGH is a large cardiac center, a large cancer center, and certainly the largest transplant center in Canada and one of the largest in North America. So that gave me the connection into the transplant world.
I'll be honest, before you agreed to speak at one of our webinars for the center, I had never really thought too much about pain and pain management. Obviously, it plays like a huge role, but it's not something that you'd think of right away. How did you find out that pain management was your thing and that's what you wanted to do?
So it's a great question. I would say that in my undergrad, I'd always had an interest in neuroscience, and I did a master's in terms of brain and behavior. So looking at learning and memory in particular, and I was in a big addictions lab. So, what are the underpinnings of addictions, et cetera. And so when I got into anesthesia, I realized how broad anesthesia was. And so, we do so many things in anesthesia, and most people think we just hold a mask and put people to sleep. And so what I realized was that, once pain became a mainstay of some of the things we did, I knew it would be a good fit. And so I had a mentor. He was a big pain guy, Joel Katz. He's now at York University and still has affiliations. We run our pain research unit together. He had done decades of research looking at, what are those predictive factors for people that go on to struggle with pain postoperatively. And so, many of your listeners won't know that, we do hundreds of millions of surgeries in the world annually. And the number is about 7%. So 7% of all surgeries, an individual will have a pain disability as a consequence of a major interventional surgical operation. And that could be for something, life-saving. It could also be for something potentially that is cosmetic, but that's the number. So there's a subset of patient, when you look at the whole kind of denominator, which is huge, that numerator of 7% is still a big number of people that need some support after this. And so knowing all of this, the things that went into what made people at higher risk for developing a surgical problem long-term, or a pain problem, not a surgical problem, but a pain problem long-term. That was kind of what I wanted to do, was to put a service in place to help, help modify the trajectory of some of those patients that don't do very well. And so I think I had mentioned earlier, we've been highlighted in the Canadian Pain Task Force as an innovation in care. And, the real call to action is that every hospital that does major surgery should have a transitional pain program to catch that small percentage of patients that need that extra support after surgery.
So do other hospitals have something like that?
Well, I think that's the whole hope of the task force report, is that now it's been placed as kind of a priority position. And transition, has so many different meanings. It can mean transition from, acute to chronic pain. That's what we're talking about. It can mean transition from adolescent to adult care, transition from, hospital to home, transition from high dose opioids to low dose opioids. There are so many terms that now encompass this transitional model that we've kind of embraced and continue to grow.
So I guess this is just something that I've always wanted to know about a lot of our listeners, but we're just going to start asking this question. But what was a lot of our guests, I should say, but what was your first hospital experience? Not like necessarily as a doctor, but as a person.
So that's interesting. I guess it goes back to being a clerk, right? And thinking about what I wanted to do as I kind of decided my profession. And
right.
So I thought I'd be an orthopedic surgeon. So I thought I'd go in and do an elective with an orthopedic surgeon. And then it dawned on me as I'm watching him do carpentry on bones that I was a terrible shop student. It was my worst course in high school. And so I figured, that wasn't the path for me. There's no way that I was going to be able to do orthopedic surgery. I think I was trying to build a shelf once and it became a box with no lid. So you didn't really want me putting bones back together. And so, going down the list of things to do, anesthesia kind of hit home. I had some cool experiences in the OR with the other side of the drape than the side that was hammering and nailing things away. And so that was kind of the right fit for me. And then when I realized how broad the practice of anesthesia was, it was a slam dunk.
That's so interesting. I don't really think I know too many anesthesiologists. I can recognize one when they walk into like a code. I'm like, that has to be an anesthesiologist because their confidence and their calmness. about when they walk into a room is very recognizable.
Yeah, I think it's, the thing about medicine and where people go wrong is not finding something that fits their personality. And so people go into medicine and they think this is what they want to do, or that's what they want to do. And you really become misaligned if you don't, internally feel that this is where you should be. And I think some of what you just mentioned, Brittany, in terms of, being, calm under pressure, being able to control the situation, not running into the corner. And some of, some of my best friends, the smartest gold medalists, well, they chose, internal medicine because they like to write things on paper. And I didn't say that too loud, but they are, they don't want to be the one that if that IV doesn't go in or that line doesn't go in, the patient dies, right? And so that is quite often, where the position we are. And we practice about 90% of what we do, is relatively routine. But when you have that 5 or 10% where somebody needs to step in and needs to take control, you have to be ready to do that. And I think I did like that on the anesthesia side. And I'm good with my hands, except for building shelves that end up to like one, a box. But, but
I mean, that sounds like a special skill in itself to turn a shelf into a box.
I suppose. So yeah.
That's an interesting way of looking at it, though. I've never really thought of different aspects of medicine having a personality or a preferred personality trait associated with them. That's a really interesting way to think of it.
And I did not in any way want to slag my internal medicine colleagues. So everybody that chooses their specialty is important to their patients. It's just,
for sure,
what ultimately you do on an everyday basis is very different, right?
For sure. So what's the difference between acute pain services and transitional pain services?
So I think we all know that in acute pain, you have an injury, you have, in the context of surgery, you have surgical incision. We all expect that pain to go away. And the limit of that is about 6 weeks. So someone has an injury, they have some pain. By about 6 weeks, we expect everyone to be completely chronic pain. And I'll then get into the transitional pain concept. But a chronic pain is something that someone has had for 3 months and it continues to persist for a long term. So 3 months is kind of that set point. So obviously there's now a gap in between acute and transitional pain. And so what's certain is that this transitional period was a novel concept. It's something that, we've been talking about as pain physicians, particularly as it relates to surgery. And so, the typical journey of somebody who would have had, in the context of surgery, a problem, and let's call it, the 10% of folks that may have an ongoing pain issue or struggle immediately after their surgery, what would that journey look like? Well, they'd probably get the story of, don't worry, it'll get better. They've seen their surgeon 6 weeks later, we'll just wait it out. They see their family doc in about 3 or 6 months. And then, maybe we should do something about this. And so what would happen to that individual on that journey? Typically, they'd either be ramped up on their various opioids, and we know where we are in terms of the opioid crisis. And by the time they see a chronic pain physician or someone who can help them, it's about 18 months later. And so, we were lucky enough to be highlighted as a novel transition in care or innovation in care by the Canadian Pain Task Force as having addressed this gap. So not just talking about it, but actually creating a service to help people with that transition period. So I hope that kind of clarifies a bit more what the transitional pain service is, or the concept.
Yeah, absolutely. Okay, so maybe since this is a transplant podcast, can you walk us through what pain management looks like for someone leading up to their transplant? So let's say like a dialysis patient who is waiting for their kidney transplant. What are some of the pain considerations or issues that they might run into along the way? And I don't know, like, is dialysis painful?
Okay, so it's a fascinating topic. And I'll tell you that the dialysis patient is one of the most challenging patients to manage from a pain standpoint, right? And why is that?
Yeah, why is that?
Well, why is that? So what clears all of the toxins in your body?
Your kidneys and your liver.
Right? You got it. So your liver metabolizes most things, and kidney clears it. And so, any drug we give you, whether that is, an opioid, or whether it's gabapentinoid on the pain side, or if you're talking about your transplant docs or any doc, it's got to be cleared by your kidneys. So somebody whose kidney is failing, attempting to give them a medication that you don't dose properly will lead to obviously severe consequences. So, it's very easy to overdose a renal patient, because if you don't get that dose correct, they'll easily become toxic. They're not clearing enough of it. And you see that a lot in terms of dialysis patients that end up in and out of the ER, especially when docs start adding opioids and things like that to their regimen. And so, we also know, and this is something that I'm sure your listeners don't know, that dialysis patients are also high risk, or renal failure patients are high risk for persisting on their opioids after surgery. And why is that? Well, let's think about it. So, what are most of the complaints that people are having trouble with, either after surgery or in general? They're usually MSK related, so musculoskeletal related, so like osteoarthritis, things like that. A renal patient will never be given an NSAID. They'll never be given a non-steroidal anti-inflammatory. They'll never be given Advil, and they'll be given all of these things that are the mainstay of patients. So imagine you come in, you have a renal problem, you have surgery, and you're given an opioid. Well, that's probably the first time you're given something that might be helpful, you think, from a coping mechanism. And then how do you go about, maintaining that kind of level of pain management? And that's probably where some of that data comes from. And so, when you talk about dialysis, talk about the renal patients, they are individuals who really need close follow-up and close monitoring, especially if you're going down the pain management road.
What about liver, though? Because if it's metabolized through the liver, why wouldn't a liver patient be just as difficult to manage if they have had a failed liver?
Yeah, I wouldn't say one is easier to manage than the other, but what's the most common condition? We have way more dialysis patients than we have liver failure patients. You can live years upon years once you land on dialysis, right? And so that it's just, there are way more people pre-dialysis or on dialysis than there are people living with liver failure.
Yeah. When I found out that we were going to be talking to you, one of the first questions that came to my mind was about, I guess, addiction and transplant. So, for instance, if somebody has an addiction pre-transplant and ends up needing a new, let's say, liver, how do you manage their pain afterwards? And is addiction a factor in that?
I think, transplant has evolved so much in the past 15 years. Look, when I started at Toronto General Hospital, the folks that ended up receiving a liver or ended up receiving a lung or receiving all of these organs, it was a very fine line in terms of who could and couldn't, and we could discuss the ethics of all of these things. And so, what we are seeing, and I'll tell you, we're just working on a manuscript about all of the transplant patients we've seen from a pain perspective in the past 5 or 6 years of having this program here. And I can tell you that we are probably the largest pain program, and we are probably the only pain program that sees transplant patients at the volume we do because of where we're situated. And most pain programs in the province are just afraid to touch a transplant pain patient because of the complexity of their medications and things like that. So what I would say is, an individual who has an addiction issue, and let's not call it addiction, it's, opioid misuse is the new term now. So addiction has all those negative connotations. So somebody who's having a problem misusing their opioid. And so if that's not dealt with a priori, and you now give somebody a new organ, why do you think that those issues of misuse and whatever those antecedent aspects that led them to where they are, i.e. their, childhood sexual abuse, their abusive relationships with their partners, the psychosocial anxiety, depression, suicidality that went into all of these, individuals being where they're at, how is that going to disappear? And so, one of the things that we are certainly seeing, and we do have some of these folks that we are trying to manage, is that, God bless our physicians and our docs that deal with these, transplant patients post-op, because they're very used to dealing with the very appreciative patient, the patient that, is just lucky to be alive, and anything they say is gold. But now you're dealing with a small subset of patients that are struggling with dual things. They're struggling with pain. They're struggling with opioid misuse. They're struggling with just coping with, with their daily life. And they have the stress of having all of these transplant in their armamentarium. And that's where they fall through the cracks. And you need some specialized help for these people. Mm-hmm. And so, this is where you can't be so friendly and be that smiling face. And you have to push back and set boundaries. And we do this all the time in our pain program. And these are the patients that will complain. And they're the patients that will, and we live in an institution where we are not so used to having people complain about us. My patients complain about me as much as they love me. And so it's one of those things of just ensuring that we at some point have to challenge these folks. If we're not going to do it beforehand, you better believe it's going to be a rough ride afterwards as well, in terms of helping some of these folks kind of get to the place. And the thing is, if you win some of those and the patients are willing to engage, their life changes significantly. And it's certainly a big win. So sometimes it's worth those fights. You don't win them all. And sometimes people just storm out, and that's just how humans are, right?
Mm-hmm.
On a lighter note, there's another question that I've always wanted to know. And maybe this is not always, but why do kidney donors complain of shoulder pain after a transplant?
No, that's a great question, Brittany, but it's an easy one to answer. So, even especially at UHN, we do a lot of laparoscopic kidney donors now. And so, once you do things laparoscopically, shoulder pain and shoulder tip pain in particular is very common. And that's just from the insufflation or the amount of air that's forced into the abdomen to do these operations. And what they trigger is the vagus nerve, or we call it your recurrent laryngeal nerve, that is embedded in that diaphragm as it wraps up and moves back up to the brain. And so that's where that shoulder pain comes from. It's really annoying, and we really don't have great ways of dealing with it, as I'm sure you know. On the ward, is the patient keeps telling you, I've got my shoulder pain, do something. It's just one of those things that, as the gas kind of evolves out over time, it gets better and goes away.
I have something to admit. I've told my patients that it's because of the operating table.
Well, it depends where. I mean,
like, it's the operating table. It's hard.
If the patient's lying on their side, for sure it could be from the operating room table. But quite often, some patients are supine, so it just depends what position they're placed in. So you could be, you could have been medical than that. You could have been right for some of them.
Okay. It's just a little bit more technical than that.
So we did mention to a few of our listeners that we were going to have an upcoming episode on pain management, and they sent in a couple of questions for you. So we'll just jump right in. Do you need to have a high pain tolerance to be a living donor? When in the assessment process is pain management discussed with living donors?
Okay, so the first one, in terms of do you need to have a high pain tolerance, I don't know how you know if you have a high pain tolerance unless you've had significant pain. And donors are pretty healthy. So, I guess my answer to that would probably be no. What I might suggest is that, one of the populations that have been really hard from an anesthesia side to manage are the liver donors, or the donors in general, because our surgeons are really protective of these highly coveted individuals that want to give their organs. And so I think sometimes we're not able to, offer the state-of-the-art treatments because, there's fear that something might go wrong, or there may be a bad outcome from something that we can offer them. And so that's something that I think is an evolution. I think you have about 1,000, I heard, liver donors out there. And, if I'm sure if you survey a small percentage of those, they could tell you that things that might have been able to be done differently that could have been supportive. But for the most part, and by and large, 80 to 90% of people do just fine with I guess, the current treatment regimen.
Yeah, I've always noticed that our liver donors always have a harder time than the actual recipient. But I always thought it was because they were very healthy before, and now we've taken part of their liver, whereas the recipients were quite sick before and probably experienced a lot of pain and discomfort and low energy pre-transplant, and now they have this new functioning organ and they're like, I feel great. Whereas the the donor is like, I feel terrible. I was fine before. So
I think, and I'll be honest with you, Brittany, I think that is an area, if we were able to maybe work a little closer to provide newer techniques for these folks, some of them may have had better experiences than they did, right? And so it's a touchy subject, though. Let's put it that way.
Okay. Will I be given options for pain meds? I'm worried about medications not working or having bad side effects. I'm also worried about addiction and dependence and would like to avoid opioids.
Okay, so options for pain meds. I mean, perioperatively and postoperatively, we are pretty standardized in terms of how we do things. It's kind of what I just mentioned with the donor population in terms of, a PCA and specific things like that. And so that's a PCA, just for the listeners, is, a little pump with your opioids, that kind of stuff. Where you get more choices is when you land with our TPS service or our transitional pain and you're having some symptoms that linger, and sure, we'll give you options. In the perioperative time frame, though, I can tell you that There are newer things. We can give you things like ketamine and lidocaine and some of these really cool things intraoperatively. And we have to chat with your surgeon to make sure they're cool with that. And if they are, then we can do some different things. We don't usually talk to you while you're asleep. So you're kind of at the mercy of which anesthesiologist and how we go about doing things. And so these are questions you can all ask your anesthesiologist in the pre-admission visit, and they'll certainly have a discussion with you about it. The big one is that whole, should I be worried about addiction, dependence, and what are the stats on that? I can tell you the stats are pretty clear. That we did a massive study, and I think it was 2014, and we published that the number of people that persist on their opioid after major surgery is about 3.1% of all comers. And so then, the news outlets picked up the phone, called me and said, Dr. Clarke, so are you making 3.1% of all people have surgery in Ontario? I said, well, no, there's this thing you call pain. And so some of the folks who land with a pain problem will still be on their opioids. And if you follow that data forward to a year, it's less than 1% of all individuals that have surgeries. And so unfortunately, if you listen to the media, 50% of anybody who ever takes an opioid develops an addiction issue or lands on an opioid long-term. And that's just not accurate when it comes to surgery. And for the most part, the goal here is to find those services and build things to protect those people that are kind of falling by the wayside and run into those issues. And that's kind of what we've done here. And for the most part, most people do not persist on their opioids after surgery.
Yeah. I guess other than the one you just mentioned, what are some other common misconceptions about opioids?
The one thing that's I hope no longer a misconception, but I still see it being done, and it's terrible when it's done, is putting people on fentanyl patches. And so fentanyl patches, for non-cancer pain, or unless you're dying, is just not going to be helpful for an individual. And you see docs that think, oh, well, someone can't swallow for a couple of days, maybe a fentanyl patch will be good. I unfortunately got called to a poor young individual who had mono, and was given a fentanyl patch and found dead in his bed 2 nights later. And so, those aren't the patients we're typically talking about. We're talking about patients that are on high dose opioids with their fentanyl patches, et cetera. And I think that's one of the things that I think really needs to be curbed from an opioid practicing standpoint. Fentanyl patches just are not useful. And I know you're going to have patients mad at me for saying this, unless you have cancer or you're dying.
Yeah, I've used it once on a patient, and that patient was in probably the most amount of pain I've ever seen.
Are there other things that can help with pain besides meds, like exercise? Are there exercises to do before surgery that could help with pain after surgery, or things to do after surgery to help with pain, massage, heating pads, walking, etc.?
So that's a good question. It's a really hot area. So one of the things, I have a colleague of mine, his name's Daniel Santamina and Ian Randall, and they're building a prehabilitation program. And so we've just started some discussions actually with the transplant docs in terms of, and I'll be honest, the lung transplant folks have been doing prehabilitation for years. It's part of what they do pre and post lung, get that exercise, get patients moving. And so, what are the things that people will be dealing with after surgery? And so, you could be dealing with that incisional pain, and that's a consequence of the nerves that have been obviously transected and cut when surgeons went in to do your operation. You could be dealing with just simple back pain. Hospital beds just suck, right? And the fact is, if you spend 5 days in a hospital bed, the likelihood of you having back pain is probably 90%. All right. And so imagine those who are in the hospital beds even longer than that. And, could exercise beforehand and strengthening of your core and strengthening all these things affect those outcomes? Absolutely, they could. And so, that's where the prehabilitation piece certainly comes in. We use, heat on some wards, right? And ice on some wards, for sure. Low impact, walking, exercise, things like that. Unless you're dealing with, back pain that has that shooting symptom down your legs with the radicular stuff, that's where walking can make things worse because you're pounding on those nerves. But for the most part, post-surgically, you want to get moving as soon as you can and as fast as you can.
Are there topical creams that can be used for pain instead of IV pills and injections?
Okay, so when you think about what a topical application of a product is, it'll work on presumably the layers of the skin where those nerves sit. And so it's certainly not usually first line for patients, but we certainly do prescribe topical medications that have specific products like a gabapentin or a ketamine or some of these other concoctions, local anesthetics that can calm that area down. A systemic drug is probably going to have an overall effect on your body. It'll have a kind of a global CNS effect. And so topicals can be useful for some patients. I would say it's typically not something in isolation that does a lot for most patients. And it's quite expensive, to be honest with you.
And that would be like maybe not best for post-surgical pain, or like, because I'm assuming that by the incision line, can you put topical creams on top of that?
Yeah, you certainly don't want to do that to a fresh wound, right? So
I wouldn't.
That would be something that we would see in clinic in a month or two or something like that. Once the wound is fully healed, and we can try things like that if the oral meds don't work.
I just wanted to address that just in case somebody's like, oh, Voltaren Emulgel on top of my surgical wound. I'd be like, oh my God, please don't do that.
Okay, these next two questions are kind of related. They're both cannabis questions. So the first one is cannabis safe for transplant patients? Does it have any effect on anti-rejection medication?
Oh boy, you want to go from one hot topic to the next.
Yeah, I was about to say, I'm like, that's heavy.
Okay,
that's the first question, which is two questions now I'm realizing.
Okay.
But yeah, so that was one question. Let's split that apart then.
Okay, so maybe let's just talk about, does it have any effect on anti-rejection medications? Because that's an easy one. Absolutely, it would. So, one of the things that people don't realize is that medications like tacrolimus and any of these other medications that are hepatically metabolized use the same CYP pathways as does CBD and cannabis-based products and THC, et cetera. And so you are going to see changes in your tacrolimus levels. And it's something that we've highlighted in the past. And the problem is folks aren't telling, look, we have 2.7 million Canadians currently utilizing cannabis for a health-related condition, and we only have 500,000 Canadians that are registered for a product. So you better believe that Canadians are using this, and just walking into the dispensaries and using their cannabis products to treat whatever healthcare condition they're using. And so what we need to do is start to actually look at this in the lab and figure out, what these interactions are. So that's a no-brainer. Of course, it's going to interact with your anti-rejection meds, and you just need to tell your docs that so they can have some ideas to why your tacrolimus levels are 3 times than it was, 2 weeks ago, et cetera. And the next part is, if you're going to go down the cannabis road as a transplant patient, please talk to your docs. We have a clinic that, in our transitional thing, we have a study right now that we are looking at how cannabis is being utilized in about 2,000 Canadians. And if you want to use a product that's been tested and regulated and validated, that we can follow and track you and your transplant team knows you're on it, come talk to us, right? We can certainly help you with that. The problem is not everybody has access to that type of a resource, and we only have so much capacity as well. So is it safe? I can't answer that. I mean, we don't know that it's safe. We don't know that it's unsafe. I can tell you I have lots of transplant patients that are using it, right? And we live in Canada, so we better start putting resources to figuring out how to do it safely. And that's really my soapbox is, this is something that we've accepted. The government has legalized it for tax purposes, and people are going to use it. And so let's figure out how we help them and get the science and the data to use it safely.
Okay, so what do we do if they are using cannabis and it is affecting their but it could, and their tacrolimus level goes up and then it goes down and goes up? Do we ask them to stop? Do they have to stop? What if they're using it for pain? Do we refer them to a certain TPS for something like that?
I think that's kind of what's been happening, to be honest with you. And so, we landed on the front page of the National Post a few years ago because one of the liver transplant patients, we saw him on the ward, and he said, look, I've been using my cannabis product for the last 5 years. It helps with my pain. I'm a CEO. I continue to work. I'm now going to get back to work. I'm sure as hell not going to stop my cannabis use. And so we said, okay, well, what are you using? He said, well, I don't know. I get it from my buddy. He grows it in his basement, and I'm happy with that. And I said, well, why don't we try to find you something that what it is, and it can be at least have a stable level, et cetera. And he said, okay, let's do that. And he ended up using kind of obviously a CBD based product in the day and would use his THC product at night. The transplant team was aware, he continues to still be a patient and is monitored, et cetera. And so I think that's the way you have to navigate this as a transplant patient. You just have to, and it's not illegal. I mean, there was a point where cannabis was illegal. It is now part of what Canada has embraced. And so we as the physicians need to understand that if patients are using this and finding benefit, regardless of our lack of science, which there certainly is a lack of science right now, and that's what we're trying to correct, that we have to engage with our patients to figure this out with them. So, if things go really awry, and we know that CBD and warfarin in particular have some significant impacts, only 1 or 2 case reports, but these are things that your docs need to know. If you're on an antiplatelet medication, you better tell your doc you're about to be, add cannabis to your regimen, things like that, just so that we can monitor and track.
Interesting.
Mm-hmm.
What if they're like pretty fresh transplant and they're like, I want to use cannabis? And what if they continue to use cannabis regardless if we say don't use it?
Yeah, I don't think you're going to be able to control that for folks that have been habitually using this. And the thing is, people have no clue what cannabis is or how to dose it. And so someone who's getting high smoking THC is completely different to someone who's using a CBD product or an oil-based product. It's, 10 milligrams twice a day or 3 times a day. And it's, people are comparing apples to oranges in one basket. And, the fact is, it's just a lot of kind of, I don't want to use the word ignorant, but a lot of kind of unknowing suppositions that all cannabis, when you say cannabis, equals weed. And that's certainly not what we're dealing with, right?
Right. That's actually a beautiful segue into this next question, which is, what is the difference between cannabis, THC, and CBD for treating pain? How do patients know what to use? There are so many strains, products, and brands.
Okay.
So many.
Another hot topic question here. Okay, so I think by now I would hope that most of the listeners know the difference between THC and CBD. And I can tell you that, what is THC? Tetrahydrocannabinol. It works on your CB1 receptor. What is that? It's a receptor that's in your nervous system. It has a big down regulation of the nervous system. So any pain drug that we give you down regulates your nervous system. So to think that THC wouldn't have an effect is kind of silly, because it does what many of these other pain meds do that we use. But what was our industry created on in Canada, and what was the story that was told, is that CBD is the magic molecule that will fix all things that are bothering you, and it has no harmful effects, etc. And it has anti-inflammatory properties, etc. I will tell you that I was pleasantly surprised at what CBD has done for some of my patients with myofascial pain, back pain, etc. I didn't think there was really much to merit to that CBD story. And we have some data and some manuscripts that we're working on now that show that there are differences in your biomarkers and inflammatory markers and things like that with patients that are using high dose THC versus CBD. So the story is CBD works typically on your CB2 receptors. You kind of wanted to know what were the difference. It also modulates that CB1 receptor. So what does that mean? So if you take THC by itself, it will get you high. If you take it in the presence of CBD, it will modulate or blunt that high part that is often reported by patients that consume high dose THC. And so the interaction of these molecules is critical. And so, what we've designed with our real world evidence study is we have the footprint of each of these molecules that patients are taking. So what those top 5 phytocannabinoids are, and we compare that to your outcome at 6 months. And so this is a one-of-a-kind database that I think we should be able to start to use over the coming years to figure out some of the things we don't know about CBD and THC. And so there are, like you said, there are tons of strains, there are tons of different products and brands, etc. What you need to know is where you're accessing and purchasing these things is actually a licensed producer, an LP. And unfortunately, because we've made this a recreational product and anybody can access it anywhere, again, people are using dispensary-like products to treat healthcare symptoms. And there is no regulation of some of those dispensary products. I'm not saying there's none, there's some, but it's certainly not at the standard of what we would do from pharma. Would I tell my patient, go use this product, it's guaranteed to be between 12 and 22%, and use that to treat your medication, to treat your condition? I wouldn't do that. I expect to have some consistency in terms of what the products are my patients are using.
Would you ever see in the future like its own specialization or clinic within the pain services at our hospital, like specialized in CBD and THC? Would that be something in the future?
I don't think it's the future. I think the time is the present.
Happening now.
Yeah,
okay.
I mean, that's what we kind of do. And on the patients that we get referrals about cannabis use, we have a cannabinoid cannabis center of excellence that we've kind of worked on and have some specific docs, et cetera, and projects ongoing. Mohit Kapoor over at Toronto Western, he runs the Shoulder Arthritis Institute. We're doing a ton of work in terms of looking at cannabis and its potential effects on OA. The time is now. This is, unfortunately, I think Canada has lost its leadership in terms of the science side once we made this completely recreationally accessible, because the companies have not taken it upon themselves to move it forward from a science perspective. And that's where the rest of the world, I think, will lead. We'll just have to see how this works into our population as things move forward.
I guess I have one more question. What would be your favorite form of pain management that is not pharmacological?
Oh, that's a no-brainer. And everybody is going to hate my answer. Use your brain. Psychology. Meditate. Yeah, patients don't. Because all they hear is the pain is in my brain and you don't believe me. Well, I can show you the numbers of patients, and the patients who are successful long-term can use their brain the same way the medications work. You can calm down that nervous system input. And, A-type people in particular, and I'm probably one of those A-type individuals, can't meditate because we can't get our brain to the place of being completely calm and fighting back. And, and there's, one of the big programs that was built by one of my psychologists, Elisa Weinrib, is an ACT-based pain program. And what is that? It's basically accepting the fact that you have pain, not completely pursuing the fact that you need to get rid of this, you need to eradicate this. And, the fact is we can't. And the fact is chronic pain is a disease that is not curable. And getting that message out from the first day a patient walks into the clinic is a hard one, and patients will often cry for about 10 minutes. But then we can actually move forward and say, okay, I won't be promising you fool's gold. And in medicine, we're not good at saying no. We're not good at saying we can't always do things. And the more we can do that earlier, the better we can, and the faster we can get patients on the track to, one honest appraisal of where they're going to land long-term and get them on that journey of how do they help themselves as much as we help them.
I was thinking you were going to say something like ice or music therapy or
I like that though. I think that really does sense. That gives you some agency, because it makes me feel like I can do something about it, and then it's a bit more in my control to me anyway. And it's easy for me to say I'm not in chronic pain.
And it's such a hot issue, Courtney, because honestly, patients either love it or they hate it. And those that embrace it and can actually do it see the immense value. And not everybody can do it. Just like not everybody will find cannabis useful. Not everybody will find gabapentin useful. Mm-hmm. But the patients that I have seen in the worst aspects and the most distressing periods of their life, those that can embrace that kind of mindful use of their brain to help counteract some of those signals are the ones that really, really do some amazing things.
Yeah, absolutely. Well, thank you so much for joining us. This has been a really, really interesting conversation. I can tell by Brittany's face she doesn't want to cut it off, but I know you have to get on the floor. So,
well, I'm happy to join you anytime you like, guys. It was a pleasure.
Yeah, thank you. Thank you so much.
Thank you.
Take care.
Thanks for listening to this episode of Living Transplant. If you have questions or suggestions for future episodes, email us at livingorgandonation@uhn.ca.
Don't forget to subscribe, rate, and review Living Transplant on iTunes, Spotify, or wherever you listen to podcasts.
And follow us at Give Life UHN on Facebook, Twitter, and Instagram.
See you next time.